good morning, good evening, good afternoon to everyone participating in this webinar from the ISSM. It's a pleasure to welcome you to the webinar about communication about sexual problems in the clinical setting. My name is Annamaria Giraldi. I am the president of the ISSM, and I'm so proud of the series of webinars we are presenting. And I want to thank you, the Education Committee, especially Patricia Pascual from Portugal, who is responsible for the planning of these webinars. For those of you who might not know the International Society for Sexual Medicine, ISSM has both a vision and a mission, and our vision is that every human being has the right to a healthy and satisfying sexual life. And our mission is to be the most respected and trusted source of information, education, and professional development on human sexual health through the delivery of world-class publications, research findings, online and in-person opportunities for knowledge exchange worldwide. And the webinar is a very good example of how we try to fulfill our mission and our vision. Among some of the benefits you have if you are a member of the ISSM, we have our member ISSM family journals, which is the Journal of Sexual Medicine, the Sexual Medicine Open Access, Sexual Medicine Reviews, which are paper journals, and we also have our video journal, which is mainly focusing on surgery. Among other benefits are the access to the University of the ISSM. We will have Ask the Experts initiatives. So if you are not a member, you can go to our website and try to see if becoming a member is something that would be nice for you. Also, I would like to welcome the moderators of our webinar. I want to thank Dr. Padmini, Prasad, and Ron Lewis for using their valuable time in moderating this webinar. Dr. Padmini Prasad is a gynecologist from Bangalore in India. She is a gynecologist, sexologist, and marital counselor. She is also the president of the Bangalore Society for Obstetrics and Gynecology and the secretary in the Council of Education and Parenthood International. And furthermore, Dr. Prasad is a member of the Education Committee. Ron Lewis is Professor Emeritus of Surgery in Urology at the Medical College of Georgia Augusta University. He's also a past president of the ISSM, and currently, among other obligations he still carries, he is a chair of the History Committee in the ISSM. So please, Dr. Prasad, Dr. Lewis, thank you for being here, and I will hand over the word to you. Thank you.
Yeah. Namaste to you all. Good morning, good afternoon, or good evening to you all, depending on the time zone. I thank ISSM profusely for giving me this great opportunity to be a part of this great program of knowledge sharing and good take-home messages. I thank my co-chair, Dr. Ronald Lewis. And now we have 3 talks in this webinar. First talk is about how to communicate what the patient does not want to hear by Dr. Bruce Cover, and establishing a multidisciplinary team, how to effectively create and communicate among a team of specialists by Estella Citrin. And third talk by Tripodi, Francisca Tripodi, how to overcome language-related inhibition. And for this, so as just an introduction, so this webinar is about communication about sexual problems in clinical settings. Clear, sympathetic, and informative communication is a key factor for patients' compliance and good management of clinicians' recommendations and prescriptions. Sexuality may be a field where communication can be challenging, as most people are not used to talk about their sexual health. Therefore, sexologists face challenges concerning their communication with their patients, and although all patients are different and their clinical situations are diverse, there are some crucial aspects that can be considered to improve clinician and patient communication. Because we have varieties of patients, because of the attitude, knowledge, upbringing, religion, culture can modify the communication. Patients are different. Clinical situations are diverse. Young, middle-aged, old-aged, urban or rural, educated and illiterate, rich or poor, open society or a conservative orthodox society. So there are various barriers and various things which can come in the way of communication, where both the client and the healthcare provider have to be comfortable discussing or taking the history and then looking into treatment. So I welcome the first speaker, Dr. Bruce Cover from USA, how to communicate what the patient does not want to hear. And Dr. Cover, he is a professor, Department of Urology, Director of Men's Health, University of Miami, Miller School of Medicine, Department of Veteran Affairs Medical Center, Miami, Florida, Secretary, Treasurer, American Society of Men's Health. Over to Dr. Bruce Cover for his talk. Thank you very much.
Thank you so much. I'd like to thank the International Society of Sexual Medicine for inviting me to be part of this very distinguished panel. My name is Bruce Cava. I'm Professor of Urology and Director of Men's Health here at the University of Miami. Next slide, please. These are my disclosures. Next slide. There's growing recognition that effective communication skills are an essential component of high-quality medical care. The manner in which a healthcare provider communicates with patients directly correlates with patient understanding and recall, compliance, emotional adjustment, and performance expectations with the provider. Improvements in communication skills have been shown to positively impact patient outcomes and have been directly associated with overall patient satisfaction. There's also evidence that healthcare providers that communicate more effectively are less likely to be involved in malpractice litigation. Next slide, please. Surveys have consistently shown that patient satisfaction with healthcare providers is often more closely aligned with not what the healthcare provider says, or for surgeons, not what the provider does, but how the healthcare provider actually says it. This survey is fairly representative of what's in the literature. Next slide, please. The attributes that patients hold in the highest regard are compassion, speaking in non-medical terms, and those who are attentive and not distracted. Next slide. More than 2/3 of patients also feel very strongly that they value their providers that were pleasant, didn't appear to be rushed, were comforting, reassuring, and confident. Finally, as someone who often runs late in the office, patients want me to apologize, which shows that I respect their time too. Next slide, please. Well, the focus of my talk is basically telling the patient what they don't want to hear or delivering bad news. It's important to appreciate that this is only one of several communication skills that healthcare providers need to be proficient in. Importantly, proficiency in communication skills are not innate. Similar to performing a surgical procedure, these skills require that the practitioner know a series of deliberate steps or tasks, as well as their order of implementation during the encounter. Watching others perform these skills has been found to be valuable, and practice-based learning using simulations have also been shown to improve self-efficacy and proficiency in these skills. Next slide, please. On the right side of the screen, we see the basic template or blueprint, which outlines the deliberate steps that characterize the majority of communication skills. And I often fall back on this when I actually forget the individual steps in a particular skill set, like delivering bad news, but I can fall back on this because it's basically, they all flow the same way. Number one, the first thing is invest in the beginning. Number two, elicit the patient's perspective. Number three, provide the patient with the medical information that they'll need to make deliberate medical decisions. Reach consensus, and then finally conclude the meeting with a summary of what was discussed, what was accomplished, and what the next steps are. We're all busy clinicians. And as I tell my house staff, this requires that the healthcare provider use all 5 of their senses, including sitting down and talking right in front of the patient, talking directly to them, never appearing rushed, listening attentively, speaking without medical terms, touching the patient emotionally, and at times with discretion physically. I couldn't come up with a task really for the nose, I'm sorry, but except to say, don't stink it up. Next slide, please. Delivering bad news is one of the more challenging clinical skills that physicians have to master. Bad news is defined as any information that adversely and seriously affects an individual's view of their future. It pertains to situations where there is a perception of hopelessness, threats to a person's mental or physical well-being, risks of upsetting an established lifestyle, or where a message is given that conveys an individual fewer choices in his or her life. Next slide. While delivering bad news is often perceived in the context of black and white of a terminal illness, in reality, there's a spectrum of gradations that must be approached in the context of the patient's view. Consider, for example, as a urologist, I often will deal with delivering a diagnosis of muscle-invasive bladder cancer to a man, and he's usually accompanied by his partner or his wife. This confers to him a diagnosis that carries a 50% survival, extensive surgery that's fraught with potential risks, carries alteration in body image and lifestyle, not to mention its impact on the friends, family, and financial consideration. But we have to recognize that bad news takes other forms too, like diagnosing a kidney stone in an airline pilot who's scheduled to fly a transcontinental flight, having to tell a diabetic male who relies on his penile implant to engage in sexual activities that it's infected and it'll have to be removed, or telling a patient that he has penile cancer and his penis will have to be amputated. Beauty is often said to be within the eyes of the beholder. Well, bad news often is within the eyes of the person experiencing it. Each of these scenarios differs considerably, but they equally may have a devastating emotional impact on the patient. Next slide. Previous generations of healthcare providers felt that disclosing bad news was unnecessarily demoralizing, particularly since many of the illnesses were incurable. Often bad news was censored from patients or their families by the healthcare provider. But contemporary patients desire honesty, transparency. Studies have shown that patients who are given bad but honest prognostic information remain equally optimistic about their future, are less anxious, and adjust better to their circumstances. Other studies have shown that patients who engage in end-of-life discussions with their physician have no higher rates of depression or anxiety, have lower rates of ventilator dependency and undesired resuscitation efforts, and also have earlier and higher rates of hospice enrollment. Next slide. From the vantage point of us as medical providers, delivering bad news is often perceived as unpleasant and stressful. Healthcare providers are accustomed to providing effectual treatment that either cures or arrests various medical conditions. When they can't perform this capacity, there's often a sense of uneasiness, lack of familiarity with the feelings of being powerless in impacting the disease outcome. In other instances, delivering bad news places the provider in a very awkward position, not knowing how a patient or family will react to circumstances, often not knowing how they will react personally to the patient's emotions. Finally, some providers relate to their own personal experiences, which often can be uncomfortable as well. Next slide, please. Teaching medical personnel how to deliver bad news is extremely important. A survey of the American Society of Clinical Oncology attendees in 1998 indicated that only 5% had any formal training in delivering bad news. 9% had formal training in responding to patients' emotions, and less than 15% felt very good about their ability to break bad news to patients. Since that time, next slide, please. Most medical school curricula have adopted generic programs in teaching medical students difficult communications. Yet, at this time, and this is a study that we did at our center, we showed that less than 40% of our own house staff actually admitted to having formally been trained in the majority of difficult communication skills. Next slide, please. Compound this with the fact that we have multiple distractions at this point that we have to deal with. We have, on average, clinicians spend up to 35 to 40% of our time engaged, of our clinical time engaged with a computer screen while the patient is sitting in front of us, trying to engage with the patient and try to engage with the patient, incorporate them into the triad. Also, next slide. At this point in time with the pandemic raging, half of our facial repertoire of nonverbal communications is gone with the masks that we wear. So we have to try to compensate in other ways. New paragraph. It's a fine line that physicians need to tread between being overtly blunt while delivering bad news and softening its impact by sugarcoating it. Patients want full and honest disclosure, but it has to be delivered with empathy, encouragement, and provide them with practical hope and support. We have to be careful, however, about using euphemisms, ambiguities, and cryptic language, which often delays and may even interfere or censor patients' understanding of the bad news. In extreme cases, patients may leave our office not even knowing that they have a potentially lethal cancer because we've sugarcoated it enough. Next paragraph, please. Next slide. So this is the SPIKES protocol, and this is the structured communication skill that has been most widely tested in delivering bad news. I would encourage you all to learn this. It's an easy thing to remember. SPIKES stands for setting up the meeting, eliciting the patient's perspective. Again, remember the blueprint that I showed before. Setting up a meeting, eliciting the patient's perception, obtaining the patient's invitation to talk about it, providing the patient with their knowledge, addressing the patient's emotions with empathy, and provide the patient with a summary and strategy. Next slide, please. So pre-meeting preparation is important. You need to mentally be prepared for that bad news that you're going to deliver to the patient, that his penile prosthesis is now infected, it's going to have to come out. Or that woman is going to have to require a hysterectomy. A lot of her sexual function, body image will be a lot different afterwards. So develop that agenda before. Practice in your mind what you're going to be faced with. Physically prepare. You want to be in a nice, quiet meeting area. Silence any of the pagers, cell phones, etc. Stay away from busy clinics and ancillary staff, and always have some tissues and water available. Next slide. Always start with the patient's perception, because that will give you clues to the patient's knowledge and emotional state. What is your understanding, Mrs. Smith, about the cervical cancer that you have? Their response will help you to gauge what kind of language you use back when you talk to them about it. It also may indicate to you any perceptions or misperceptions or misinformation that they may have. And also, you'll want to know at that point what family members that they would want to be involved in some of the decisions moving forward. Next slide, please. Always fire a warning shot before you actually deliver the bad news. It gives the patient a chance to settle in and understand that this is going to be a very serious conversation. Mr. Smith, I have some very bad news to talk to you about, or we need to discuss a problem that just came up. And that'll give the patient that opportunity to really prepare for what's going to come up in the next several slides. Provide the patient with knowledge. Now, the first time I did this with a simulation, very interesting, I basically gave a monologue to the patient. I just rambled on and on and on and on. And at the end of it, the patient looked at me and said, "So what did you mean?" And it was a simulated patient, which was kind of interesting and I didn't even stop. But this takes practice. Again, a lot of these communication skills require practice. Speak slowly, avoid medical jargon, provide pauses for the patient to process the information, and ask them to read back. Ask them questions frequently. Did you understand what I mean? Can you tell me what I just said to you? That will help you understand whether they're following along. Next slide, please. And finally, empathy is a two-step process. Remember this. Empathy involves understanding and appreciating someone's feelings or predicament, and then communicating back to them that you understand it. And that's a very important component of it. So it's two steps, and that involves verbal and nonverbal communications. Next slide, please. Finally, providing a verbal summary of what was discussed in the meeting, anything moving forward that needs to be done, any business that needs to be attended to in the future for that patient. Next slide. So we did our own communication simulation at our center a couple of years ago. This was about 5 years ago, and looking, we actually put our residents to teach them communication skills in front of a TV screen with a digital patient, very much like telehealth works, and we didn't realize how useful this would be back then. But basically, they were communicating on the left side of the screen with one of our residents, communicating with an African-American gentleman, giving him a diagnosis of prostate cancer. On the other side, to the right of that, we see another. That's a clinician responding to the verbal responses that the residents are discussing. What we did was we graded the residents on a variety of different communication skills, and we found that disclosing medical errors on the right side, on the full right side of the screen, really had the lowest scores. So, and again, the residents were taught the various processes, but this requires practice. It requires them to watch us in the office seeing patients, and it requires them to go home, to go practice this in a safe environment like a simulation like this. The residents in response they responded that these meetings were very awkward, uncomfortable, and they clearly lacked confidence in delivering bad news. Next paragraph, next slide. So in conclusion, Communicating bad news to patients is an essential communication skill that's common to any field in medicine. It's not commonly taught. We may think that we're teaching it, but many of our residents, even coming into a postgraduate training program like we have, up to 40% indicated that they never really learned these skills. In order to optimize these skills, healthcare providers need to know the steps, see how they're incorporated through observation of others, and implement them through practice. Thank you very much.
Thank you very much for that wonderful talk. And it is really a very tough job about delivering a bad news, to especially when it comes to the sexual aspects, because no man or the woman will tolerate a bad news about the sexual incapability or any of the problems, and especially serious diseases like cancer and other things. And so very well you could enumerate what are the steps that you have to take and how you can improve your communication skills, because that itself is a very good art and a talent to communicate in the best way. So I request Dr. Ronald Davis to take up a few questions regarding this stuff.
Padmini, Prasad, the Q&A will be handled at the end of all the presentations.
Okay, then we will move on to the next talk, establishing a multidisciplinary team, how to effectively create and communicate among a team of specialists. But this is by Dr. Estela Citrin. She is a gynecologist, FECMS, coordinator of the Sexual Medicine Diploma, University of Uruguay, member of the Educational Committee of ISSM. Thank you very much. Over to Dr. Estela Citrin for her talk.
Thank you so much. And it's a pleasure for me to be here, and appreciate and thank the honor of being in this webinar by ISSM. Can I have the next slide, please? These are my disclosures. I have no conflict of interest. And when I started to prepare this webinar, I asked myself a question: who should be part of this multidisciplinary team in sexual medicine? So maybe now we can, Meryl, let's have the poll. Who should be part? Sexual medicine expert, gynecologist, urologist, all of the above, none of the above. Please vote. And I want to say, while you are voting, that I really enjoyed Dr. Scava's presentation, because he gave us really a good start for this talk, because you can see on his slides that how important it is to have a multidisciplinary team related to what patients need. So we have, I agree with you, we have 75% of you thinking that all of the above are important for a multidisciplinary team. Great. Can we move on, please? The next slide. So I went on to review who definition of health, sexual health and sexuality, and I think we all agree that we all should have the standard of care of sexuality. We also know that ISSM and NG made a petition that saying that without sexual medicine, medicine is not such. And the problem is that in many countries, like here, for instance, in Uruguay and many other countries in South America, sexuality, human sexuality is not included in our medical curriculum. And also, it's important to see that sexual medicine is a branch of medicine concerned with human sexuality and its disorders. So how can we try to understand and help a patient without being a multidisciplinary team? Can I have next slide, please? So I think this is very interesting. We have a biopsychosocial approach that we should go with all these patients, and it's very interesting that it applies to other areas of medicines. For instance, if we have a diabetes patient that is overweight, we know that his biology will go on maybe badly because his sugar levels will be high. But if this goes on and on with us in our consultation, we should address also the psychological and the social part of it. So this approach is very important for all the consultations that we have as specialists, but in sexual medicine, it takes that approach to be more taken seriously. Can I have the next slide? Okay, so we have this ICCS International Consultation on Sexual Medicine by ISSM, and you can see here that there are 5 steps that we need to follow when we are addressing a sexual medicine patient. And we see now that in step 1, you have the possibility to have this basic evaluation, and they say that there is mandatory to have your sexual history, medical history, and psychosocial history. So when you follow this guideline, you see that you might need some further investigation, like testings, and then when you reach the treatment part, you have to be able to have your team and have your approach in the psychosocial work and the medical devices or therapy that you might need. And then your follow-up will also need to have scheduled with other doctors and specialists. So this is the importance of having a biopsychosocial approach and having your medical team all together. Next slide, please. So about the sexual history, it's all about the patient, right? You have to you are at the clinic and you see your patient complaining about symptoms, emotions, feeling fear about something that just happened, as Dr. Kava said, because maybe he's having bad news from you. And I highlighted conditions there because I wanted to share with you what happened to me at the beginning of this pandemic here in Uruguay. I had a 72-year-old male coming to this public consultation I have in this public hospital, which is the Hospital Pereira Rosell, a human reference from women health in Uruguay. And this patient came to me just after he went to his general practitioner complaining about an erectile dysfunction, and his doctor said, well, you are 72 years old already. This might happen. So just, well, you need to deal with this. And as he wasn't kind of happy with this answer, he went to see like a fortune teller lady. You know, this lady came to his house and he said, okay, you don't have like a spell on you. You shouldn't be able to have this, you should be able to have your intercourses because no one made like a spell on you. And why I brought this? Because I think these cognitions are important, because if I am not able to understand why the patient came to see and to seek a specialized help with his erectile dysfunction, someone in my team should be able to explain this to me, because otherwise I won't be able to help my patient and I won't be able to explain how the treatment will go on. So of course, effective and empathic communication will help you, the communication with your patient and the relationship, as it was previously said. Can we have the next slide, please? So a multidisciplinary team should be always centered on the patients and the couple needs. And I agree with you, because 77% of you said that all of the above. And I think I made on purpose, I didn't put other specialists on the list, because I think that maybe you need to be very aware that the first person that your patient sees when he comes to your clinic, maybe it's a nurse, a receptionist, has to be trained and has to be also very empathic with your patients, especially, for instance, with transgender people. And maybe you need, among the patients, among the treatment to your patient, you need to have other specialists, maybe not always with your team, but you have to be able to call them and ask them for help so that you can best provide your quality assistance to your patients. Can we have the rest, please? So why should it have to be multidisciplinary team? Because it gives us the opportunity to learn from each other, to have the other perspective of the dealing with the patient, and maybe the patient feels best talking with you some aspects of his discomfort, and maybe has another approach to another person who gives his other possibilities or ask the right questions. And because of absolutely this approach will benefit the patient and the couple, no doubt. Next slide, please. So, and how to communicate in your team? Well, there should be one expert to guide this team, but this leadership can be shared, because maybe you are the first person to start with this patient, but then you understand that he's having a neurological disease that needs to be treated before. And then you have to be able to communicate and to be able to have your expert and leader in these topics. Of course, the team must share your passion to help your patients. And all these different perspectives are useful to provide important information, like the example I said before about the cognitions. And if I learn something for my friend and colleague Francesca, supervision is very useful in all areas, because when we are dealing with difficult situations and you are very into the problem, you maybe miss things that are easily resolved. So we should be able, to ask for help and refer, and give us the opportunity to learn from others. So I am convinced that the holistic and combined approach is the best option for our patients. Next slide, please. So now the puzzle is complete. If you have your patient and the couple in the center, you have you can go on with all of them. Thank you. You have your front desk person, that's maybe a nurse or a receptionist that is also empathic and receives the patient with a good smile, and ask what are the things that would make him feel comfortable. Your Dr. Kaba said, just have water and have some tissues there. So also the sexologist or a sexual medicine expert, you have all your specialists with you, and then all the therapy that you will be providing, maybe physical therapy, maybe other pharmacological therapies with you. This is important to be comprehensive and holistic. So I think the next slide is quite the end. These are the take-home messages. We have to trust, to have a work team, and share and have leadership to be able to deliver the best approach to our patients. We don't have to be afraid to say, I don't know, and to ask and refer. Thank you so much.
Thank you very much for that really very good lecture with plenty of take-home messages. And in the best interest of the patient, it is always better to have a multidisciplinary team where we can interdisciplinary and also interdisciplinary team exchange of ideas and referrals and the discussions about the patients. And we can, in the best interest of the patient, we can really give the very best to the patient or to the couple, especially in the matters of sexual health, because we can compensate. If we don't know it, as you said, there is nothing wrong in telling that I don't know, maybe you may be helpful in this case. So that is really a wonderful gesture from any specialist. So all the steps described, the 5 steps to follow to address the patient, and while taking sexual history, how it has to be patient-centered, and how we should have an effective and empathetic communication. All these things go a long way in giving really the best to the patient in the best interest. And so that, because we are touching the most emotional aspect and most integral aspect of the patient when it comes to the sexual health or the sexual medicine. Thank you very much for that talk. So next we will move on to the talk on How to Overcome Language-Related Inhibition by Francisca Tripodi. She is a psychotherapist and sexologist, Institute of Clinical Sexology of Rome, International Online Sexology Supervisor, IOSS. Thank you. Over to Dr. Francisca for your talk.
Thank you very much, and thank you to Patricia and Annamaria for inviting me to this prestigious ISSM webinar session. So I want to talk to you, to share with you some tips from my clinical experience on how to overcome some patients' inhibition in talking about their sexuality. Of course, all of you know that there are barriers in taking the sexual history, both from the side of the patient and from our side, clinician. But the good news that I want to deliver is that with very small changes, even if we are not well trained, we can make a difference for our patient, and we need to, we have to know that with 10 minutes of our time, we can really change the suffering, deep suffering or a deep anxiety of our patient. So my first slide is what can inhibit the patient. So our common mistakes are the following. When we don't introduce ourselves, what is our specialization, what we are going to do with them, explaining the step of the assessment, the medical assessment, the psychological assessment, the social cultural assessment, not introducing the aim of the sexual history taking. I will come to that later. Not disclosing the confidentiality rules. Not asking for clarification on what a patient is saying, for example, not allowing or encouraging the patient to ask a question to us, not asking about the patient's feelings and not mirroring the patient when we see that he or she is changing his face. Overrely on medical jargon and all the scientific or terminology that the patient maybe don't know, and if very, very important, if we have a judgmental attitude. Next. There are several strategies to overcome inhibition from the patient. I will go through them very quickly. First of all, we need to take care of the setting. We should think that if we have a clean, nice room in which, as you see here, the computer is on a side, we don't answer the phone call, the patient can fully see us, and we can stay in front of the patient, and our attitude is open and we can smile. This build a kind of warm atmosphere. Psychotherapists or psychologists maybe don't have the table, maybe they can have 2 chairs. At 1 meter, 1 meter enough distance is the best option. But anyway, take care of your setting. Build the comfort of the patient before asking sexual question. Make sure that the patient feel comfortable in your office. So maybe you can start with the medical history. Almost all the patients are really keen to deliver the information on their medical history. Or if the patient is tense, you may offer a glass of water to the patient. You may go with calm, you may smile. So make sure that your patient is quite comfortable in talking to you. On the body language, I will address it later, is very important. Our patient need to understand that we are calm, that we are willing to listen to them. So our tone of voice, our face, our attitude is really, really important in overcome their inhibition. We should use inclusive languages. And what it means, person-centered, gender-neutral. For example, we don't talk about, we don't ask about the husband, the wife, you know, the girlfriend, the boyfriend, just ask about the partner. The language should be not ableist to include all the people who has some vulnerability, some disability, and open to change. We need to adapt our language to the patient and not the patient to adapt to ours. Next. We should, this is very important with a transgender patient, but not only with them. We should use the correct pronouns or terminology. And it's very nice when a clinician, you know, just put a flag in the door or in the room saying, you know, inclusive care for LGBTQ+, or something like that. So the patient that may have different orientation, different gender, or a different diverse relationship may just have a signal that you are open to listen to them. So maybe you can ask which is the best pronoun, the pronouns that you want that I use with you, what is the name that I should use with you, and that make the patient feel more relaxed. Of course, this is very important also with adolescents. We need to rephrase and explain if we see that the patient is silent or looks like he or she is not understanding what we are saying. So we say a sentence, and if we don't have a feedback from the patient, we have to be available to rephrase and explain something one or two more times. We need to be sure that we all have a common understanding of what we are discussing. And this is very important, especially with the couple. When we do a couple session, a couple consultation, maybe one of them is saying something and the other is understanding something else. So maybe we can just summarizing at a certain point of the assessment, just saying, for example, from what I understand, if I understand well, you are saying this, this, and that. Am I correct? I understood well, or we can ask the other partners, do you understand what your partner is saying? And this ensure a common understanding, build a common knowledge during the consultation. And very, very important, we should avoid assumption. If we expect something from the patient just because he or she is looking in a certain way or as a certain age, or we are stereotyping and we are a little bit blind on something, it's very common that we will hear not what the patient is saying, but what we want to hear, what we want to listen. So this will lead quite surely to incorrect, wrong conclusion. So we should really be aware to avoid assumption. Next. About the body language, as I told you, the patient really, as we see the body language of the patient is able to see our body language. So as much as the clinicians stay relaxed, calm, attuned to the patient emotion, maintain eye contact, show interest, is able to actively listening to the patient. So you move your head, you look into the eyes of the patient, you follow the emotion, and you are aware also of the proxemic. As I told you before, you don't have to be too close and not too far from the patient to have a good communication. The more the patient will be less tense, less anxious, less embarrassed, less ashamed. Next. So we should go for a proactive sexual history taking. We don't have to wait the patient to ask a question or to disclose their his or her sexual issues. We should always keep in mind that we keep 10 minutes of our time to ask to take the sexual history. Basically, we have two ways to take the sexual history. We can have a quick screening if the patient is not coming with a sexual problem, or we can take a deep sexual history taking. If the patient is in the room with the partner, a relative, we can ask that person to wait in the waiting room, and he or she can be invited after our question. And we need to have a transition to asking sensitive questions, so we can phrase this transition this way. I'm going to ask you a few questions about your sexual health. Sexual health is very important to overall health, so I ask all my patients this question. So normalize this kind of discussion with the patient. And disclosure the rules about confidentiality. Everything you tell me is confidential. If there is anything you don't want to share with me, you don't want to answer, we will just move forward, and maybe we can talk about it in another moment. Or maybe if you want, if you prefer another member of the team, if you are working in a team, maybe a male, maybe a nurse, maybe someone else, we can make an appointment with that member of the team. So we ask permission. Is it okay with you now? Before I begin, do you have any question or sexual concern you'd like to discuss? Next. So these are the brief, the few important questions to take to have an impression of the patient. Have you been sexually active in the past year? And of course, if the patient say yes, we go on. If the patient say no, maybe we can ask, there is any reason that holds you back from having a sexual life or getting this way? So we can understand why the patient is not having something that is very healthy for him or for her. Do you have sex with men, women, both, or others? So with this question, we let the patient know that we know that people can have sex with both gender, that our orientation can be very flexible, variable, and we are open to listen to all of this story. And even if the patient say that he or she has a husband and a wife, or is in a monogamous couple, anyway, just ask how many people have you had sex with in the past year, because we all know that we can have, of course, an husband or a wife, but we can have sex with other people too. So in this way, we let the patient know that we are aware of these things and we are willing to listen to collect all this information. Any concern about your functioning or your sexual experience? So we try to open the door about any sexual concern the patient can have. Can you tell me if the patient has some concerns or some things to say? We go on and we invite them to tell about their problem in their own words. And from that point on, we can go much more in deep. After finishing this kind of question, we can say, okay, we have covered a lot today. Is there anything else in your sex life that you think I should know in order to better assess your problem? So always keep in mind that this is a good question to end the consultation. Next. I bring to you three cases of inhibition from the patient. Case one is the patient has difficulties in describing maybe the body parts or the process or the experience, the sexual experience. So we can gently teach the patient with the correct terminology by linking the terminology, the correct terminology with this language, air language. For example, I take too long to come, and we can answer, when did you first notice this problem with delayed ejaculation? Or I wish to have sex, but nothing moves downstairs. Do you mean that you have sexual desire, but not an erection? Just to, make a common understanding. Or I can easily get, how I can say, wet. Well, I'm glad you don't have any problem with lubrication. What about your mind? So here we open the door to ask about subjective arousal, for example, in a woman. Next. Case 2, the patient is reluctant to disclose all the sexual and relationship details. Of course, we need to show much sensitivity in respecting and acknowledge the right to keep private. We can take this occasion to include emotional and psychological health issues. So the patient say, I don't know where to start. I'm not familiar with talking about my sexual life, my sexual issue. And we can mirror him. I see you are tense. This is normal. Many people feel uncomfortable when it comes to describe their sexual life. May I guide you with a few questions? We need to stay consistent in willing to take the sexual history. Or the patient can stay silent and be embarrassed, give signs that he or she is embarrassed. And we can say, okay, it is a hard key for you, you know, maybe you can share with me how you feel now, or why it's difficult. So, because your emotional health is just as important to me as your physical health. So we let them know that we are there to listen to their feelings, to their emotion. Or I do not want to talk about it. Everything is fine and there's nothing else to say. So maybe the patient want to close the door immediately and, you know, in a bit angry way. So we need there to be really firm and to continue to take the sexual history. Okay, I'm happy you don't have any concern. Still, it's important that I assess your sexual health. Do you mind answering a few questions just to be sure you keep yourself safe and healthy? Next. Third case is the patient feel embarrassed because of their condition. They have a chronic illness, they have a disability, they are old, or whatever is the condition that make them feel more vulnerable. So here in this case, we should be even more proactive because we know that all this population really need our help. So we should normalize the desire to have sex, even when the condition brought up some difficulties. And we should know and we should discuss all the benefits of a satisfying sexual life. Benefit in terms of our body, our physical health, and our psychological health. So the patient can say, sex is not an issue anymore, nothing functions as before, and I got tired of embarrassing situation. And we can say many people with diabetes notice a change in their sexual function. Sometimes they do not know that there are solutions. Shall I ask you a few questions that can help me in identifying exactly your problem? Or since I've got a cancer, everything changed in my sexual life. I have no desire. I don't know if my partner still wants me. And we don't talk about that. This is really a frequent situation. So we address that is very frequent, is very normal, that we understand because the fears go high and the medical process can affect the relationship. So we may invite the person to think, what about inviting your partner for a session? We could face it together. Or I'm too old for that. This is something that in Italy I hear very, very often from female, postmenopausal female. And I can say sexual intimacy can be very satisfying at your age and it's good for your overall health. Maybe you can see if there is still room with wish and motivation for that. So I encourage the person to explore if there is a motivation for having a sexual life again. Next. So my take-home message is take the sexual history as a routine. Just do it. Stop excuses. Okay, I don't have the training. I don't have enough. I'm not confident. I will give you in the next slides a lot of reference, good reference and video that you can watch to be more confident in asking these few questions. So save 10 minutes for it and build your network, as Stella said. Be proactive, open the discussion, learn a set of important questions, and try to work on your cultural competence. I'm not talking here about race or ethnicity only, but the cultural competence to deal with, all the diverse relationship, all the diverse orientation, all the diverse gender, all the diverse sexual preferences or paraphilias, you know, try to detect, identify your own biases, learn by your own mistake, because we all learn by doing mistake, by taking the sexual history, and reassure, be empathic and open-minded with the patient. Thank you very much. Here you have, next slide. Very good references for that give you tips for sexual history taking. Thank you.
Thank you very much, Francisca, for that lucid and very informative lecture. And you took us all, and it was like one teaching class, like how you have to take history and how the patient should not feel inhibited, and various strategies that you explained it so well, how the setting has to be, how you should be comfortable with the subject, and also you should make the patient comfortable. And body language is really very, very important in any communication. And you should always use the inclusive language, and also how you can use so many times. See, there are, when you take it as barriers, many people are not used to talking in terms of medical terms, like the actual terminology for the various body parts like vagina, pelvis, etc. And in so many places, there will also be sexual slangs, or depending on the local languages, they use different terms. So the various barriers like gender differences, attitudes about sexuality, and some places really a sex negative culture, and the culture, and you are also mentioning when once there is menopause, so that they think that it is the end of sexual life. So even in our place also, that is the very common misconception that our ladies have. So if you say, how long can we continue the sexual relationship? That itself is a big question for them. So you should understand this various, it is not like discussing about cough, cold or fever. Anything about sexual matters is really a very difficult thing to communicate. So this communication can be, with all these three talks, we can say that with the communication, it can be verbal communication or non-verbal communication. It can be open communication in a non-embarrassing way. And we can also use various books, visual media, and questionnaire and Dropbox method if they are not feeling comfortable in the first instance. And we should have a good feedback, review, analysis, and program modification depending on the patient. So the client has got some needs like confidentiality, non-judgmental attitude, comfortable setting, and devoid of embarrassment. And in similar way, the healthcare provider has also the duties and questions, having a proper knowledge, good communication skill, sympathetic and empathetic attitude, devoid of myths and misconceptions, and has to be comfortable with the subject and observe very high ethics and maintain trust with the patients. So when we are talking about the body language, one study says 7% of what we talk impresses the client, 28% of tone of the voice impresses, and 55% of the body language is the one which impresses or which gives a good communication, which can include your facial expression, eye contact, your smile, position of hands and feet, or how you sit, or your gestures, all these things, and the listening skills. So all these things go a long way in having a good communication, making the patient comfortable, and also we can extract the best from the patient, and we can also give best to the patient. So that is how the capacities to discuss sexual history and other activities, sexual activities, can help prevent so many unwanted things in the society. So this is very important, and we should also say we can expect changes but not miracles. So we have to develop a deeper trust and give them the miracles if possible. Thank you very much. And all the three talks were so impressive and very good take-home messages. And I think our audience are really happy with the good messages. Thank you very much. Thank you, ISSM, for giving me this opportunity to moderate. Over to Dr. Lewis for taking up the question answer session.
Yes, we have several questions from the audience. here. And for Dr. Kava, the first question is, can you hear me?
Yes, I can.
Sometimes in the setting of a busy acute hospital, it can be very difficult to have time and privacy to be able to break bad news in a gentle and empathetic and effective way, and not to mind how to prepare to do it. Any advice how to work in a situation like this?
It can be tough. There's no question about it. Busy city hospitals and stuff. It would be nice to scope out the hospital before. Find your little conference room or find a little area that you can do. That's what I usually will do. I'll bring patients into a conference room, or you know, sometimes the nursing staff will have a little lounge. I'll ask them if they mind if I bring somebody in there just to talk to them for a little bit. So I think there's always a little space someplace. It's not always ideal, but I think that most people can find someplace.
A quick follow-up question too. How important is it to have other family members or significant others present when you're delivering these bad news scenarios?
It can be very important. I mean, I think a lot of this relates to the patient and what they want. Certainly with that invitation, which is the third component of the Spikes protocol, you have to ask them if they would want to have anybody else in the room. Sometimes you have to make a date with them. You know, you may give them that warning shot, and at that point say to them, listen, you know, this may be a lot of information, a lot of, you know, very sensitive information. Would you want somebody? This has been very difficult for us during the pandemic, because for us very often our clinics, that people, it's almost like you need to have security. You know, there's security constantly around, not allowing patients' family members up to see to be with them during the visits. So you have to ask for special permission up front, but I think that's the best way to do it. I think the best suggestion that I would have is know what news you're going to disclose, know which patient it's going to be. Perhaps if it's an outpatient clinic visit, maybe, you know, make when you get back that pathology report, or when you get back something that's going to be very sensitive, have all the clearances made up front so that the patient can bring in whoever they want with them. I think that would be the best way to do it.
Okay, Dr. Citron, the next question's directed for you. What sort of treatments are the physios providing in the multidiscipline teams?
Oh yes, I saw. Thank you, Dr. Lewis. I saw the question on the Q&A button, and it seems I failed to answer it directly to the person who asked. Actually, overactive pelvic floor is very important, and we know that this is cause of pain, both women and men. And here in Uruguay, we are 3 million people country. We have an association of physical therapists that provide special care for these patients. They have like all this settled. They prepare the pelvic floor. They tell them how to do the exercises, because sometimes we ask them to do these Kegel exercises, but we don't teach them to relax. Actually, we teach them to contract even more. And they provide very useful, for instance, electrodes, therapy, strategies to relax the muscle. And the last article I read about persistent genital arousal disorder had very good outcomes with physical therapy. So they are very, very helpful in this MD team.
Okay, just a quick follow-up question. Years ago at Mayo Clinic, when we had a fertility clinic, and we worked as a fertility specialist for the female and male, we would find it very, very good for having conferences of the various people involved in the couple's treatment. But you don't see that very much in either time-wise or being able to sit down with patients and with a multidiscipline team. How do we get around these barriers? And is it more important for the multidiscipline teams to meet and discuss options and approaches to these patients than having patients have this multidiscipline team facing the patients at one time?
Absolutely. I for instance, with the man, this male I told you before, I called his physician and had a conference with him. I called as the psychiatrist. I told the patient to attend. It's not like the patient needs to feel like in a with a jury of specialists sitting in front of them. They should be able to have this appointment and be guided by one lead. This is why a leadership is so important. So someone should be leading the team and giving the opportunity the patient to have this special appointment with the persons in charge. I agree with you totally.
The next one is for Dr. Tripathi. Just one of the abbreviations on your slides, SHT. The question.
Sexual history taking. Sexual history taking. Sorry,
No
if
problem.
I used that.
And we had a comment also about your presentation with Dr. Perlman.
I read it, yes, and I thanks Dr. Perelman Professor Perelman to be here, and of course he's right. I want to I can say I completely agree with your comment. If you want to read the comment, of course is saying that maybe in my first case in which the guy say it takes too long to come, and I answer with the delayed ejaculation. Of course, I'm giving already a label to something while I don't know if it's a problem or not. And I agree completely. The first question should be, what do you mean by that, or something like that, and clarify before. This was just because of the time, the time frame of the presentation, and so I wanted to just to give the participants the way we can discuss with the patient about the correct terminology. But you are completely right. Thank you for the comment.
You know, I particularly liked one of your key slides was in the tradition of Michael Perlman, who years ago introduced us to how do you talk about sexual issues. And he came up with this slide. It was a wonderful slide called the open-ended questions. And I like that one slide you had for breaking the ice-breaking questions. And I think that all of the people who participated in this conference should look at that slide again, because the three important points that you mentioned on that slide are the best ways to begin communicating with people about issues that they're reluctant to talk about.
Thank you.
Finally, we have one last question. I'll leave that for any of the panel to respond to. Oh, no, this is for Dr. Tripathi again. Hospital gynecologists and obstetricians in my country have 10 minutes to speak to the patient. They claim they don't have enough time to conduct a conversation about sexual concerns. I teach them to allow for questions and concerns for patients. However, they fear not to know what to answer and not having time to answer comprehensively. What is your advice when there is so little time in a physician's life to interact with the patient?
Okay, I encourage you all to watch a few videos that I put in the references, because in those videos it's clearly evident how in few minutes you can address some sexual issue. Of course, maybe you have only these 10 minutes and you can't go in deep in a sexual history taking, but you can make another appointment with the person, or refer, if you detect or identify that there is an issue to be discussed more in deep, you can refer the patient to another member of the team, or to another moment, or to another specialist, a psychologist or a urologist or a gynecologist, to discuss only that issue in a more relaxed way. But I anyway I will suggest all the clinicians, all the healthcare providers to open the discussion about sexuality, and maybe you can say to the patient, okay, we don't have now the time to face it, let's take another appointment. And we focalize on that.
Okay, I thank all the panelists for their answers to the questions that we received. And with that, I think I'll turn it over to Annamaria to close the seminar, which was very well done by all the participants. Thank you.
Thank you so much. We actually have a few minutes more, so I have a question. I cannot write them because that's because I'm on the panel. Very often we get information from the patient that the patient don't want to share, maybe about having a malignant sickness or having, been infidelity in the couple. So how do you deal with that when you communicate with the patient and maybe with the couple or relatives? I mean, this is an open question for the whole panel.
I think that I answer first. I think that, of course, if in the first session you have the couple, maybe you don't challenge the couple with this kind of question. But if you have the impression that something is going on with one of the two or both of the two, maybe you can ask for an individual session with both of them, and then in that context you may ask some other question, talking in the third person, like many people in your situation decide to find sex elsewhere, or decide to, or it happened that in life you meet someone else. Did it happen to you? So you open this question when you are in privacy with the patient, and you reassure the patient about the confidentiality.
Thank you. I don't know if Estella and Bruce have any comments to this.
Just wanted to say that sometimes this is this is why they are having a sexual dysfunction, maybe. So if the patient comes alone, I always ask, does your partner know you are here? And most of the time they say, yes, she does, or no, they don't. And I always reassure about confidentiality. And when in the case that the couple is sitting outside and then he will come afterwards, I do as I always do with the adolescents, for instance, when I ask the mother or the father to stay outside, I always say, well, what kind of information do you want me to share with your parent or with your partner, or what kind of things you don't want me to say by any means? And I take a special attention to that. So this is how I usually work.
Thank you.
Yeah, I agree with that. I think that that's the best way to do it, to isolate the patient from the family members there and find out what they would want. I have patients undergoing prosthetic implantation who, even in the recovery room, they don't want their family members knowing what they had done. They just want, will make a call and say that they had surgery, or they had a hernia repair, something like that. There's some, a lot of privacy issues that go on, and not violating that trust is so important. But when they do want, I try to get them to be honest and truthful with relatives or their significant others, at least, because it's important that they're all on the same page. Very often, when I'm breaking bad news about a diagnosis of prostate cancer to a couple, the wife is usually thinking, well, is my husband going to be around in 5 or 10 years? And the guy is thinking, well, am I going to have erections in the next 5 or 10 years? And so that's always a challenge, to try to get them on the same page.
Thank you so much. Ron, did you want to add a comment?
Yeah, I just wanted to add a couple of things to one of the questions for the physicians who feel like that it's tough to get sexual history into their evaluation for different diseases. And that's what's great about these questionnaires that you can have them fill out in the office. Patients are waiting to see you. Why not take advantage of trying to explore those sexual areas? And finally, I'll end with one funny story. And what's important about getting surprised and attaining your composure as a physician. I remember at Mayo Clinic, I had been seeing this patient for sexual dysfunction for several visits. He was from Europe. And at many times I met his significant others on a couple, maybe 3 visits. And finally it came to the day of the penile implant, and I went out to speak to the family, and I met, he had his significant other with him all the other visits. And I went out to the lobby to meet with the wife. It was the first time I'd ever seen her. Be ready to have all things happen to you in sexual medicine. And it was somewhat difficult to keep composure, but you realize you had to keep these things in a proper perspective.
So that's real life. I can just add to that actually the ISSM many years ago developed a screener. There's a screener for men and a screener for women, where you ask about sexual problems, whether people are distressed about it, and then they can put in the end, it's a 10 question, they can put in the end whether you would like to talk to a healthcare provider about this. So this is a very easy way to screen whether there's something that, and also get an idea what the problem is before you talk to the patients. So having said this, I just want to thank the moderators, Dr. Lewis, Dr. Prasad, for moderating this great session. I want to thank you, the faculty, Francesca, Estella, and Bruce, for giving these wonderful lectures. I think we all learned from it. We have been more than 140 participants. So I really hope to see you again. I hope you learned a lot. And the next webinar will be in September the 30th, and that will be erectile dysfunction, state of the art from current guidelines to novel therapeutics. So we are jumping to something completely different, or maybe not completely different, but to another topic. So I wish you all a good day, evening, night, wherever you are. And thank you all for being here. And thank you to the faculty. Thank you so much.
Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Bye-bye.